introduction to anemia, first we'll see how the red blood cell is formed. It is formed through the process, as we all know, it is called as erythropoiesis, and the place where it takes place in the bone marrow, that one unit is referred to as erythron. Erythron is the unit where RBC formation takes place. So this, as we all know, first there is hematopoietic stem cells, which forms multipotent stem cells. What is important is lineage specific growth factors. For the RBC to form, we need to have these two growth factors, GATA1 and FOG1. FOG is nothing but friend of GATA. So these two are very important lineage specific growth factors. This will help in stimulation of colony forming unit erythrocyte, CFE. After this point onwards, it is erythropoietin which gives stimulus. Erythropoietin gives the further stimulus for production of RBC. After that, we have pronormoblast. Why pronormoblast is important for us? Because first morphologically recognizable RBC is pronormoblast. And through electron microscopy, if we see through electron microscopy, first hemoglobin is as well is formed over here. Hemoglobin is first formed over here. Then comes early normoblast. Why is this important? Because hemoglobin, we can start seeing hemoglobin through microscopy as well. Through microscopy, first it is seen in early normoblast. After this comes intermediate, then the late normoblast. From bone marrow, it comes out to blood as reticulocytes. Further, reticulocytes mature in one day to form erythrocytes. Okay, so normal concentration of reticulocytes are 0.5 to 1%. So dealing with anemia, the factors that cause anemia up to the bone marrow level can be classified into either maturation disorders or hypoproliferative disorders. Okay, this can be due to any maturation defect like sickle cell anemia or thalassemia, or it can be due to hypoproliferative when there is not enough erythropoietin or not enough iron, folate, or B12. So broadly, we can classify at the starting, we can look it into two ways. One is hypoproliferative. One is in the blood. What happens in the blood once it comes into the periphery? What can be the cause? It can either be due to blood loss, which can be acute or chronic, or it can be due to hemolysis. The red cell is formed properly, but it is broken down. So that can further be intravascular and extravascular. So this is the basic how their RBC is formed, and at what level, if some factor affects, what type of anemia is formed. So we saw the basic. Next, we'll go to case challenge. So now what we'll be doing is, we'll just show you two case scenarios. Can anyone of you volunteer for the case? Yeah, so hello Rishabh, from which college are you from?
Vaidai Medical College.
You're from Vaidai. Which year?
Final years.
Okay, I'll just give you a case scenario and you should proceed with the case. You should approach it in a proper way, okay?
Yes.
So we'll see how you approach the case and come to diagnosis, okay?
Yes.
So this is the chief complaints. A 11-year-old boy, he comes with complaints of recurrent pain abdomen for the past 3 months, okay?
Okay.
Now you can choose as to what you want, okay?
Yes.
And
history, I'll start with this.
So first, what do you do? A patient comes with this chief complaint. So what do you do next?
You'll take a proper history.
Yeah, very good. You'll take a proper history. So this is the history. The kid has recurrent right upper quadrant pain, which is associated with nausea and vomiting. Past history, it suggests of the patient being lethargic, less active. He doesn't involve in usual play activities. He's had several episodes of jaundice in the past, and he has had 2 episodes of sudden fall in hemoglobin levels for which he underwent transfusion. Family history shows that his cousin is diagnosed with a certain type of anemia. So this is the history. So with this history, can you make out something?
So it's either the liver or a gallbladder pathology.
Okay, why do you tell it's a gallbladder pathology?
First, there is pain in the right upper quadrant.
Okay.
And,
it's associated with nausea and vomiting. Yeah. Okay, fine. Yeah. We can think of gallstone.
And there's jaundice.
Okay. What may be the cause of jaundice now over here?
Increased hemolysis.
So, okay, fine. So you can think of this particular anemia being hemolytic anemia, correct? No?
Yes, yes, sir.
That is evident from the history, because
Yeah.
the child has 2 episodes of transfusion. He's been
Yes.
having jaundice, and now he's due to increased hemolysis, he's having gallstones. So which
Yes.
type of gallstone do you see in case of hemolytic anemia? Can
Mixed.
you tell us? Huh? Okay, fine. So next, what do you want to choose?
Examination.
Okay, fine. So let's go to examination. The child is conscious and cooperative. Vitals, pulse rate is increased because of anemia. Rest all the
Yes.
parameters are normal. Pallor is present, icterus is present. No lymph adenopathy and edema. Abdomen, there is tenderness at right upper quadrant, and splenomegaly. Other system examination was normal. So
Okay,
this is the examination finding. Now what can you infer from the examination findings?
So that as there is hemolytic anemia, there is pallor and icterus, and because of increased like splenomegaly can be the cause of increased hemolysis.
Okay, fine. Which type of hemolysis can you infer from this?
Extravascular hemolysis.
Okay, fine. Extravascular hemolysis you are telling. So where do you look for pallor? Could you tell us?
In the lower palpebral conjunctiva.
Okay.
In
Any
the
other?
soft palate. In the palms.
Okay.
Nail beds. And
okay. By
skin.
looking at our palms, can we tell the level of anemia? What is the...
Less than 7 grams per deciliter.
Yeah. How do you see? What do you see?
The creases.
The creases you see. Okay, fine. Then icterus. Where do you look for icterus?
In the bulbar conjunctiva.
Okay.
The soft palate.
Upper bulbar conjunctiva.
Yeah, and the palms and the skin.
Okay. By looking at the color of jaundice, can you tell which type of jaundice it is? Is it possible?
I don't know, sir.
Okay. Audience, could you tell us? Okay, lemon yellow indicates hemolysis. So that is important for us over here. So then there is splenomegaly as well. So with this, what do we tell? It is a hemolytic picture. So could you come to a differential diagnosis using this history and examination? Could you come to a differential diagnosis?
So maybe thalassemia.
Okay. Then
maybe
what else can be? Okay, first
G6PD
you told
deficiency.
there is hemolytic anemia, correct? No, through history. So
yes.
anything, so through this history, what are the types of differential hemolytic anemias you can think of?
Inherited conditions.
Okay, inherited conditions like
thalassemia or G6PD deficiency.
Okay,
or
thalassemia, what inheritance do you find?
Autosomal recessive.
Okay, fine. G6PD?
Autosomal dominant.
No, that is hereditary spherocytosis.
I don't remember.
Okay, fine. G6PD is X-linked. Okay, so okay, fine. You thought of these things. So that was, this is a differential diagnosis. We can think of all these things: enzymopathy, hereditary spherocytosis, anything causing hemolytic anemia. Okay.
Yes.
So next, what do you like to see? We have done good examination. We have come to a differential diagnosis. So now, how do you further approach the case? You have all these
investigations
tests available for you.
Yes.
Yeah, but you can't randomly choose. Just go in order. It will be better.
Sir, a complete blood count with a peripheral smear.
Okay, fine. Complete blood. You will want to choose complete blood count. Okay, this is CBC.
Okay.
CBC tells us that there is anemia.
Yes.
There is some amount of lymphocytosis. Next, what is important for us is RPI, Reticulocyte Proliferation Index. That is 2.5. What does that suggest?
There's increased reticulocytes in the peripheral blood.
Very good. So reticular proliferocyte index is higher. Since RPI is higher, now we can think of the cause being peripheral destruction of hemoglobin, leading to peripheral destruction of hemolysis. At bone marrow, there is, so to compensate for that, at bone marrow, there is increased proliferation. That is what we can incur from RPI. Next, RBC indices. RBC indices, what does it show?
Like there's no iron deficiency or a megaloblastic anemia because all are normal.
Okay, fine. That is what you told. Next, what do you like to see?
Peripheral smears.
Okay, peripheral smear, I think so will come a bit later. Anything else? Since we are going in approach way, anything else would you like to see? How would you like to confirm
Liver function
hemolysis?
tests for jaundice because of jaundice.
Okay, liver function test, what does it show? Okay, that it shows that there is jaundice. And if ALP is raised, it shows that it might be obstructive pattern because of gallstones. So now, would you like to check for hemolysis? If hemolysis is going or not?
LDH.
Yes, you look for LDH and haptoglobin. But both shows it is normal. So now, since these are normals, we can be more confirmed that it is extravascular rather than intravascular.
Intravascular. Yes.
So correct, no? So yeah, now we have come to the thing that it is extravascular hemolysis. So now, what would you like to see?
The cause of extravascular hemolysis.
Yeah. So now we can go ahead with which investigation in this?
Peripheral smear or.
Okay, fine. We'll go to peripheral smear. Peripheral smear showed this.
Okay. So it looks like because of spirocytes, it may be hereditary spirocytosis.
Yes, very good. So we have come to the diagnosis of hereditary spherocytosis. So this was the case challenge. Very good. You have approached it well, and we have come to diagnosis of hereditary spherocytosis. Thank you very much for
Thank you, sir.
Okay.
Thank you.
So this is how we approach a case. Now we have one more case, one more similar case we have. If anyone else would like to volunteer now? Okay, Avantika raised her hand. Yeah, Avantika, are you audible? Can you hear us?
I can hear. Yes, I can hear you.
Yeah. Hello, Avantika. Which college are you from?
I'm from BMC, sir.
BMC. Good. Which year?
I'm in final year.
Okay, you are in final year. So you are well versed with anemia, no?
Yes, sir.
Yes. So can you move ahead with the case?
Yes, sir. We can move ahead.
So yeah, these are the chief complaints. 58-year-old gentleman came with complaints of fatigue, dizziness, and decreased mentation. Okay.
Yes, sir.
So next, what do you like to do?
History, sir. First history.
History. Okay, fine. This is the history. Patient has been having the above mentioned symptoms since 5 days. There is no history of fever, chills, nausea, vomiting, melena, or hematochezia. Past history, patient is hypertensive and he has been having osteoarthritis. He's been treated for the same. There are no history of any ulcer, bleeding disorders, or hemorrhoids. Drugs, the mentioned drugs are being used. Family history, nothing significant. Personal history, there's history of alcohol consumption. So this is your history. What do you make out from this history?
So it may be because of.
So first, let's see the chief complaints.
It may be.
It may be.
It may involve something related to his liver. So.
Okay. So why do you tell so?
He has significant alcohol consumption, or.
Okay, fine. We'll take alcohol consumption as one of the positive history. Next, why do you think we have asked all this negative history?
So like fever and chills for any infective causes, and
okay, what are the infective causes like you can think of that can cause like anemia?
Hemolytic anemia, which can happen secondary to any
common anemia. Very common in India.
Malaria.
Yeah, okay, fine. Then melena, hematochezia, why do we look for that in elderly? Is it significant?
Yes, sir. He doesn't have any bleeding diastasis, and he doesn't have any evidence of carcinoma. And
What carcinoma?
By melena, we're looking at an upper GI bleed, and hematochezia is passage of frank blood. So colon carcinoma. So
By melena, you are looking for upper GI bleed. So he's been consuming naproxen. Anything you can think of?
Peptic ulcer. It can be because of NSAIDs.
Yes, NSAID use causing the ulcer. Good. So we can one thing we can tell, it can be a drug induced. Second thing, we can tell he is an elderly, he can still have occult bleed. So we can think of any malignancy. Third thing, his alcohol consumption is there. If there is alcohol consumption, can it lead to any nutritional anemia? Is it possible?
Yes, sir. It can. B12 deficiency is more common.
Okay. Then?
Even folate deficiency by itself and water
iron deficiency anemia, anything can occur. Can alcohol by itself cause anemia? Can alcohol cause bone marrow suppression, and can it cause anemia? Is that possible?
Yes, sir. Direct.
Yeah. So with just the history, what all could we make out now?
Hello?
Yeah, with this history, what all could we make out?
So it may be a direct bone marrow toxicity due to the alcohol.
Okay. Then,
or it can be an area of chronic disease, because we'll have to investigate further if he has any malignant underlying cause.
Good. Then?
And drug induced.
Yeah.
If
okay.
It's
so this next we'll move to examination. So in examination, because he's been hypertensive, his BP is high, pulse rate is high, he's conscious and well nourished. Well nourished is significant. Pallor was present. There's no icterus, lymph adenopathy or edema. CVS, a grade 2 systolic murmur was present. Per abdomen, hepatomegaly was there. Spleen was normal. Lungs examination as well was normal. So what can you infer from examination?
So he has pallor, first of all.
Okay, good. So that confirms anemia. Next.
Yes, sir. And there's no icterus, so we can rule out hemolytic anemia.
Yes, we have ruled out hemolytic anemia now. Good. Next.
There's no lymph adenopathy, so maybe there's not an infective cause or even a malignancy.
Yes, very good. Next.
And there's no edema, so
the case, he's not gone into congestive cardiac failure, which might be a complication of anemia. Yes, you ruled out that.
Sir.
Good.
So it's not gone into failure. And it's a grade 2 systolic murmur. Maybe it's a flow murmur because it's a hyperdynamic circulation. So it may just be because of, so it's just a flow murmur for now. And per abdomen, we can see that there's hepatomegaly with no splenomegaly. So hepatomegaly can just be due to the alcohol, like starting fatty liver.
Yes, fatty liver would have caused hepatomegaly. Okay, fine. In CVS, if there is murmur due to actual pathology, could that lead to anemia by any chance?
Yes, sir. If it's like vegetations and the blood passes through, it can lead to hemolysis, or if there are prosthetic valves.
Yes, very good. So in that case, we can think of hemolytic anemia as well, correct? So with this background, what can be the differential diagnosis? We have already discussed. So it is pointing towards a hypoproliferative anemia. It can be nutritional, so iron deficiency or megaloblastic anemia. It can be occult blood loss because there was no evidence of blood loss in the history. It can be due to bone marrow suppression. It can be drug induced, or it can be due to his age, any hematological malignancy as well. So we can think of these disorders, correct? So, okay. Now let's see the investigation. What are the investigations you look for?
So starting with the CBC first.
Okay, fine. You want CBC. This is CBC.
Okay.
So what do you infer from this?
So he has mild anemia, which goes up to 9 gram per deciliter.
Can you tell based on hemoglobin levels?
No, sir.
Mild,
No,
moderate,
sir.
severe classification?
So I think I'm not very sure, but 9 to 11.
It's okay. We'll discuss that in detail. Next,
Yes,
you can just, if you're not sure, okay, fine. Hematocrit is reduced. Okay,
it's
next
reduced.
we'll look at RPI. What does RPI suggest?
RPI is, it should be 1.2 to 2%. So
Okay.
it's reduced.
Okay.
So it indicates
Again,
a bone marrow suppression.
Yes. So we can confirm that it is not bone marrow suppression. It is hypoproliferative.
Hypoproliferative,
Yeah.
yes, sir.
Yes. So
And
next,
the RBC indices, MCV and MCH are decreased, which means it's microcytic hypochromic.
yeah. So we are having a microcytic hypochromic picture.
Yes, sir.
Yes. Good.
And
next,
the platelets are 48,000, which
okay,
is decreased.
yeah, which will again now point towards bone marrow suppression. Correct?
Yes, sir. Yes, sir.
Yeah. So this much you could make out. So
Yes, sir.
now let's go back. Next, what do you see?
So I'd like to look at, so now I have in my mind microcytic hypochromic. So iron studies.
Yeah, very good. Next, we'll go for iron studies.
Yes, sir.
So what are the differentials which you think of? It is microcytic hypochromic now. You can narrow down, no?
Yes, sir. If it's microcytic hypochromic, I would first think about iron deficiency anemia.
Okay,
it can
good.
be due to thalassemia.
Okay, fine.
It can be due to sideroblastic anemia.
Fine.
Then
good.
anemia of chronic diseases.
Yeah, okay, fine. These are the 4 differential diagnoses which we can make out. So further, by using iron studies, we can confirm. So these are the iron studies.
Yes, sir. And the serum iron is high, which is unlikely to be iron deficiency anemia.
Yes.
But the total iron binding capacity is high. It should have been low. And the serum ferritin is high, which is the storage form, which is high. So it's not clinical iron deficiency.
Yes. So this much you can infer from the iron studies. Very good. Next, what do you want to see?
So I think I'd go for a peripheral smear.
Okay, fine. This is the peripheral smear findings.
Numerous microcytes, hypochromic, few macrocytes, and few normocytic normochromic. So
what can we inform from peripheral smear?
So it shows both smaller cells and bigger cells. So it's anisopoikilocytosis.
Yeah. And what is this picture called when there are 2 different types?
A dimorphic blood smear.
Dimorphic. Okay. Now we can make out dimorphic. What are the differential diagnoses when you consider dimorphic anemia?
So it can be both iron deficiency and B12 together.
Yeah, that is very much possible in this case since he is alcoholic. Next.
Yes, sir. It could also be sideroblastic anemia.
Yes. Okay.
And yes, I think that's
okay. These 2. Even if you're treating for the iron deficiency anemia, even then we can have a dimorphic picture. So next,
yes, sir.
What do you look for? Okay, you can see stool for offered blood is again negative. So next. Avantika?
Hello, I'm sorry, sir. I got my internet switched off.
Yeah, tell now. You can continue.
Yes, sir. So the B12 and folate levels we could check?
Yeah, sure.
Okay. So the B12 and folate levels are within normal limits. Okay.
Yes.
So on the peripheral blood smear, can we do special staining?
Yes. What do you want to do?
A Pearl's reaction or
yes. On doing that, we could see Papillary bodies. Very good.
Yes, sir.
Yeah, good. You asked for it. Yeah, we could see Papillary bodies.
Yes, sir. So that would before we go for a bone marrow aspirate, I'd like to do a special staining on the smear itself. And yes,
you
sir.
found out Papillary bodies. That was a very good thing which you did, and that was a finding. Papillary bodies was seen. Now,
yes, sir.
Next.
So,
finally, how will you like to confirm by doing? Do you want bone marrow aspirate?
So, yes.
Yeah.
Yes, sir. So sideroblasts on Prussian blue staining.
Yeah.
So we can.
What is your final diagnosis now?
Sideroblastic anemia.
Yes, very good. Why sideroblastic anemia? What is called sideroblastic anemia?
So sideroblastic anemia. So on peripheral blood smear, we'd be able to see ringed sideroblasts, and also Pappenheimer bodies, as you said.
Yeah.
And it's an anemia. It happens because of an iron overload kind of situation. And yes, it's so because of the increase
in this case, it is usually mainly due to alcohol. Alcohol induced sideroblastic anemia.
Right,
alcohol as well can induce sideroblastic anemia because alcohol has directly the rate limiting step ALA synthesis. No, alcohol can go and inhibit that in few cases. So alcohol itself can cause sideroblastic anemia. So that was the case. Okay.
Yes.
So very good, Avantika. Thanks for volunteering.
Thank you, sir.
Yeah. Thank you. So that was about how we approach a case. So let's now look at it in detail. Why altered mentation? It was just because he was under the alcohol. Any doubts? No. So no doubts. So now, as we saw, how we approach the case. Approaching anemia in anemia, history and examination is very, very important. Like we saw in our previous two cases, just by history and examination, we could narrow it down to only one or two differential diagnoses we could keep in mind. So history and examination plays a very important role in anemia. So let's see, how does age affect? How does age affect at birth? If it is at birth, it can be due to a RH incompatibility or ABO incompatibility causing hemorrhagic disease of, or it can be due to hemorrhagic disease of newborn like vitamin K deficiency or ABO incompatibility and RH incompatibility leading to hemolytic disease of the newborn, or it can be due to hemorrhage like caput or cephalohematoma, which can again cause anemia by itself, or certain types of hereditary spherocytosis, severe variants of hereditary spherocytosis can present at birth itself. Next, like around 1 year or so, sickle cell anemia and thalassemia become prominent because the HPF starts to decrease. Once the HPF decreases, thalassemia and sickle cell anemia shows up, correct? No? So by 1 year of age, if we can diagnose anemia, then it will be probably due to sickle cell anemia or thalassemia. In children, it can be mainly it is nutritional or GI infection. Mainly since they play around, it can be due to GI infection, worm infestation, or it can be nutritional. Since it is very prominent, malnutrition is very prominent in mainly in Indian children, we look for nutritional anemia as well. Then it can be due to certain syndromes like Fanconi anemia, congenital Diamond-Blackfan syndrome, or dyserythropoietic anemia. All those things you can think of in children, but those are rare entities. Mainly common, we think of nutritional or GI infection. Then if it is middle age, we'll again think of nutritional because pregnancy comes into picture where there'll be increased demand, or slightly younger age because of puberty, again it will be nutritional. If in females, because of the gynecological problems, because of menorrhagia, that itself can lead to nutritional anemia. Then in elderly, when it comes to elderly, we should think of malignancy. That's why any elder male or a female who has crossed her menopause, we should always send stool for occult blood because we think of any colorectal carcinoma, and other common entities like hemorrhoids or diverticulosis can be there. In diverticulosis, again, you ask for history of constipation is important. Constipation is important. And throughout this, any chronic illness throughout the age group, if the patient is suffering from chronic illness, Then it can be due to anemia of chronic disease, infection, or endocrine disorders like hypothyroidism can always affect. Next, or it can be due to CKD or hematological malignancy in older age. Next, coming to address. How is the address important? Again, malaria predominant areas, we can have G6PD, thalassemia, or sickle cell anemia. In India, thalassemia fits from Gujarat. We can think of thalassemia because it's more common. Chhattisgarh is more, we can think of sickle cell anemia since that is more common over there. Gender, again, inheritance. As we discussed, X-linked disorders, usually we get G6PD deficiency, or congenital sideroblastic anemia is again X-linked, so more common in males. That is how gender plays a role. Then comes occupation. Occupation, any toxic chemicals like lead or metal poisoning, all these things, or any exposure to radiation which causes bone marrow suppression, paint, again lead exposure, all these things can cause anemia. Next, chief complaints, how the patient presents to us. Anemia presents with diverse symptoms. So it can be fatigue, weakness, lightheadedness, headache, all these things, jaundice, tachycardia, palpitation, chest pain, cold distal extremities, and again claudication pain, all these things. So diverse symptoms anemia presents with. So that is why examination in anemia is important, because with just fatigue we'll have to diagnose what the type of anemia is. And fatigue itself is why there are multiple causes for fatigue and weakness. Anemia itself may not be the cause. So diverse complaints anemia presents with. Next, coming to history. Then we'll take the history in detail. So first, how we'll look at anemia is, one, it can be due to blood loss. As we saw in our previous cases, it can be due to blood loss, or it can be due to systemic involvement, any systemic diseases which can lead to anemia, or it can be due to RBC disorder per se, which can be hyperproliferative or hemolytic picture. So we will go approach the history in this way. We'll approach the history this way. So anemia due to blood loss. Yeah, Akanksha, it will be shared, and this will be put up on YouTube also, and notes will be shared, okay? And I'll try going a bit slow. So blood loss, if it is acute blood loss, it will be very much evident from the history itself. Okay, so it will be an acute picture and blood loss is very much evident. Next, coming to chronic. If it is chronic blood loss, it will be usually, in case of females, it will be due to AAV. Menorrhagia is the most likely cause. If it is elderly, you can think of GI loss like melena. It can be due to peptic. So if it is melena, we can suspect peptic ulcer disease or some GI malignancy like stomach malignancy or something, or hematochezia like lower GI malignancy. And it can be due to simple hemorrhoids, which causes bleeding again. Or it can be diverticulosis. So all these things causes through GI loss, or it can be hematemesis, which in that case, we can think of upper GI causes as the cause, like a simple ulcer itself can cause hemorrhoids, hematomesis, or variceal bleed can cause hematomesis. So all these things can be a cause. Then if it is renal involvement as well, it can lead to hematuria, like stones or nephrotic syndrome, which produces hematuria that causes anemia again. So we have ruled out now blood loss through history. One, we rule out blood loss. Second, we'll think of systemic involvement. So what are the systems that can get involved? One is the simple anemia due to chronic illness. Can you guys tell through the chats why chronic illness causes anemia? Anyone? What is the mechanism for the chronic illness to cause anemia? Yes, one is through interleukin 6, which directly causes inhibition. Another one is hepcidin. Yes, very good. Very good. You guys are very firm with your theory. So what is left is how do we approach? So that is what we are doing today. Second, it can be due to our infections like fever with chills and rigors, very common in India, malaria. If it is certain abroad, we can think of babesiosis, like Europe and all, we can think of babesiosis. Then next, we can think of GI system. We can think of GI system involvement. GI system involvement, if the patient complains of abdominal pain, then we can think of worm infestation. So we can ask for history of passage of worm in stools. Then if it is colicky pain in the abdomen, then we can think of lead poisoning, or we can think of gallstones as we saw in our case today. And even chronic pancreatitis as well can cause. Then comes diarrhea. Then comes diarrhea. Diarrhea can be the cause. Why diarrhea? Because certain malabsorption syndromes, if malabsorption is present, even the vitamins don't get absorbed. Vitamin and iron absorption will be inhibited. That will cause anemia. And worm in stools, which we spoke about, or any hepatobiliary diseases like Wilson's disease or primary biliary cirrhosis, all these things. Hepatobiliary diseases as such can cause anemia by direct bone marrow suppression. Okay. Then we can think of dysphagia. If dysphagia is there, very evident, Plummer-Wilson syndrome. Dyspepsia and abdominal pain is there, then we can think of any occult bleed through ulcer. Occult bleed through ulcer. So then what else we think of? If there is any bleeding tendency in the patient, if there is a history of bleeds and all, we can think of thrombocytopenia leading to thrombocytopenia as the primary disorder, which has led to blood loss, which has led to anemia, or any coagulation defect as well we can think of. Then fever as such, only fever, if it presents with night sweats, we can think of lymphoma, leukemia, or TB, or any other infections which can cause the anemia will be typhoid, TB, infective endocarditis, all these things, or any autoimmune diseases as well can present with chronic fever. Next, which is a system that can be involved. Next, coming to kidney. What are the features in chronic kidney disease? Uremic features, nausea, vomiting, GI, abdominal pain, all these things. All these uremic features can be there, along with edema, periorbital puffiness. If these are there in our examination and history, we can think of CKD, chronic kidney disease causing. Why CKD causes? We already have the answer, Siddesh, very good, due to decreased erythropoietin. Then comes cardiac causes. As we discussed previously, because of defective valves or SAB, when the RBCs rush through these defective valves or through the vegetations, there will be hemolysis that causes anemia. Then weight loss is very important. History of weight loss is very important because many chronic diseases along with TB and malignancy, all these things can account for anemia. Then what is very important is hypothyroidism. We should never forget hypothyroidism. Hypothyroidism itself can cause anemia. Again, due to bone marrow suppressant effects, hypothyroidism can cause anemia. Never forget to rule out hypothyroidism as one of the cause. So constipation, dry skin, weight gain, cold intolerance, all these things. Then history of bone pain, again important because of certain malignancy like multiple myeloma, leukemia, or myelofibrosis, lymphoma, wherein there will be bone marrow infiltration causing bone pain. So there can be sternal tenderness, all these things. So now we have ruled out two things. One is blood loss. One more is systemic involvement. Next, we'll go for the red cell disorder per se. Due to bone marrow suppression, there will be direct bone marrow suppression. Then anemia due to red cell disorder per se. So what all we can think of red cell? One is peripheral destruction of the red cell, that is hemolytic anemia. Hemolytic anemia, two types. One is intravascular, one more is extravascular. Intravascular, what are the features that we can see if it is intravascular anemia? We saw intravascular anemia we saw extravascular anemia in our case. Okay, fine. That was hereditary spherocytosis. If there is intravascular, we'll only see anemia, yellowish discoloration, that is jaundice. And because of hemoglobinuria, we'll see hematuria as well. Red color discoloration of urine as well is seen. So what are the hemolytic disorders that can cause anemia? One is enzyme deficiency. Enzyme deficiency like G6PD. What is through history? How can we make out episodic? It is episodic, that is classical. So like something like consumption of fava beans or something infection, whichever causes increase in the reactive oxygen species, again consumption of few drugs, that will lead to anemia. So it is episodic. So episodic anemia will point towards enzyme deficiency. Then we can think of PNH. PNH, one is sudden onset, early morning hematuria. So since it's paroxysmal, sudden onset will be there. Early morning hematuria, it is classical of PNH. Why early morning hematuria? Anyone? Why is it early morning hematuria? Yeah, good. Good. You guys are very good with the concept. Next, in PNH means there will be other thrombotic episodes also will be there. Certain thrombotic episodes will be there. And mild to moderate anemia will be there. There will be pancytopenia. So approach to pancytopenia itself is totally different. That we'll deal with in our further sessions. In some different session, we'll deal with that. Then it can be autoimmune hemolytic anemia. Again, very important cause. In this, we'll rule out other etiologies. Okay, like infections, drug exposure, autoimmune diseases. We'll discuss this in detail in our further. Then if it is fever with chills and rigors, as we already saw, malaria. Malaria causes again hemolytic jaundice. Then it can be due to mechanical trauma. Mechanical trauma means when the RBC are running through the vessels, it undergoes damage. So that will be due to vigorous exercise history, or it can be due to valve surgery, defective valves or prosthetic valves themselves can cause hemolysis. Yeah, in bongo players, very good. Or thrombotic microangiopathies. In this, we can look for what is the pentad. What is the pentad you will see for, and what is the disease. Anyone through your chats, please reply. Yes, TTP, HUS, good. What are the features you look for? You'll usually look for fever will be there. There'll be neurological deficits. Organ failure will be there along with purpura, mainly purpura. Purpura along with previous history of diarrhea. If the person has suffered from diarrhea along with this, and then comes with all these symptoms of purpura, organ failure, neurological deficits, and fever, then we can think of thrombotic microangiopathies, HUS, as the cause. Which strain? Which strain? O157H7. Very good, very good. Then coming to the extravascular hemolysis. Next, extravascular hemolysis will be a triad of anemia, icterus, yellowish discoloration of spleen, and splenomegaly. This is the triad we see in extravascular hemolysis, because over here, hemolysis is taking place in the reticuloendothelial system mainly. It is taking place in the reticuloendothelial system, mainly in the spleen. So due to the splenic, there will be increased destruction of RBC in the spleen. So there will be more infiltration, which will lead to splenomegaly. This will lead to splenomegaly. So we see splenomegaly over here. So what can be the causes? Hereditary spherocytosis or electrocytosis. In this, mainly if there is any defect, structural defect in the RBC, since the RBC is a fragile structure, it can change its shape however it wants and move through the splenic sinusoids. But if there is any structural defect, that time it becomes rigid. That time it cannot pass through the splenic sinusoids. That time we will have extravascular hemolysis. Yes, hereditary spherocytosis and elliptocytosis, very good, Vaibhav. Spectrin ankyrin mutation we can think of. Hereditary spherocytosis, depending on the severity, it can present at birth only with marked jaundice, or it can present later in the life. There will be history of, since most of them are transfusion dependent, there will be history of recurrent blood transfusion, and they are prone to go for aplastic crisis. So what is the cause for aplastic crisis? Which infection can cause aplastic crisis? Anyone? Yes, very good. Parvovirus infection that can cause aplastic crisis. So in aplastic crisis, what happens? There will be sudden dip in the hemoglobin level due to the crisis. So during that time, the patient would have undergone transfusion. So that is what you can get in the history. So this one, then we can think of sickle cell anemia. What is the mutation in sickle cell anemia? Mutation in sickle cell anemia. Point mutation, yes. What happens if you can? Yes, good. So what you look for in sickle cell anemia, there will be recurrent infection, there will be pain crisis. Crisis will be there because the sickled RBCs, they go and block the vessels. So each organ can undergo transient ischemia, which causes pain, which causes, like dactylitis can be there, acute chest syndrome can be there, peripheral Raynaud syndrome can be there. All these things can occur due to pain crisis. Then again, just like how we saw in spherocytosis, there can be crisis over here as well, and there will be impairment of growth and development. So growth delay can be found. Next, last one we can think of is thalassemia. Thalassemia, again, depending on the severity of thalassemia, it can be, there'll be recurrent blood transfusion, history of recurrent blood transfusion. Since it is chronic and seen in child, there'll be growth retardation, recurrent infection, and transfusion related complications can be found. So we can, through history, hemolytic anemia we have ruled out. Next, we'll see at the level of bone marrow, there'll be decreased RBC production. Most important cause in our country is nutritional anemia, iron deficiency anemia, that being the most common. It is widespread. widespread. So we'll look for iron deficiency anemia. Iron deficiency anemia, there will be history of chronic blood loss, or there will be increase of inadequate diet, or there will be history of pregnancy, where repeated pregnancy. There won't be enough gapping between the two pregnancies. That will become important. So either puberty or pregnancy due to increased demand. And there will be in children, we can look for history of pica, consumption of abnormal things can be there. Next, there is megaloblastic anemia. Megaloblastic anemia means it will lead to certain neurological complications, which can cause tingling and numbness, paresthesia, all these things. So this is important. Then it can be certain bone marrow disorders. This we have already seen, bone pain due to infiltration, or it can be lymph node swelling, can be found out through history, which can indicate lymphoma, malignancy, or TB, or TB can be a cause, or it can be due to decreased stimulation of bone marrow due to chronic kidney disease. So this was what we look for in the history and categorize anemia into different. So we can broadly categorize into all these things: decreased RBC production, hemolytic anemia due to secondary systemic disorder or due to blood loss. In the past history, we can look for any blood transfusion, history of blood transfusion, or recurrent infection, crisis, as we saw, repeated, as we already discussed, repeated pregnancy or time between the two pregnancy. And again, gastric bypass surgery means there won't be enough absorption. So that becomes important. Again, this can cause megaloblastic anemia, or history of TB, chronic disease. TB is a chronic disease, so that can cause anemia. Or if there are history of any bleeding tendencies due to the blood loss, that itself can cause anemia. Family history, how it's important? It depends on the inheritance pattern. So autosomal dominant, we can see in hereditary spherocytosis, or autosomal recessive, we can see in sickle cell anemia and thalassemia, or it can be due to X-linked inheritance like G6PD, hemophilia, all those things, congenital sideroblastic anemia, all these things. Drug history is very, very important in anemia because there are like large number of drugs which can lead to anemia. So this, we will have to ask about consumption of drugs. Like we have just listed out, tried to list out very few names of the drugs, but the list goes on. It's very large. There are very large number of drugs that can lead to anemia. So we should ask about drug history. It is very, very important. So few examples are NSAID-induced gastritis, erosive gastritis. This is very important and very common as well. Or antimalarials or sulfonamides or nitrofurantines, which can precipitate G6PD deficiency. Penicillin and methyl dopa causing autoimmune hemolytic anemia. Anyone knows the mechanism behind penicillin causing autoimmune hemolytic anemia? If you can answer in your chat. Then comes phenytoin or carbamazepine, methotrexate. All these things can cause nutritional anemia because it blocks the folic acid pathway. Or liquid antacids or calcium or tetracycline, it inhibits absorption of iron, or certain indigenous medicines as well. We don't know the mechanism, but they are known to cause anemia. So drug history is very important. Yes, very good. You guys know it. Then comes personal history. How is it important? Again, diet can cause nutritional anemia, strict vegetarian, megaloblastic anemia. Fava beans can lead to G6PD deficiency. Alcohol, it causes macrocytic anemia. So this is from our history. Once we are thorough with history, once we have taken thorough history, we'll further go to examination. What we look for in examination? First, his nourishment. If the patient is emaciated, it becomes very evident that it is either because of a chronic infection, malnutrition, or malignancy. If then we'll go through vitals, what we can get to know, if pulse rate will be increased because there will be anemia, hyperdynamic circulation will be there. So pulse rate will be increased due to hyperdynamic circulation. We can find water hammer pulse. But if pulse rate is decreased, then we can think of hypothyroidism as the cause. Since bradycardia will be there, hypothyroidism, again, it's very important. It can cause anemia. Then increase in BP, if it is there, we can think of chronic renal failure as one of the cause. Then if temperature increased, again because of fever, if respiratory rate, we can think of pulmonary congestion. This is due to secondary to CCF. Since one of the complication of anemia is CCF, that can lead to pulmonary congestion, which will lead to basal Krebs. Then you can think of Kussmaul's breathing in case of chronic renal failure again, or increased JVP due to CCF again. So these are the things which you look for in the vitals, which is important for us. Next is head-to-toe examination. Very important in anemia is head-to-toe examination. First is pallor. In that, first is pallor. Pallor, what is it? Waxy appearance of skin and mucous membrane. Waxy appearance of skin and mucous membrane is pallor. This is what we look for in anemia. So what are the sites? As one of the participants had already mentioned, it is lower palpebral conjunctiva on the tongue, especially tip and the dorsum of the tongue, mucous membrane of the palate, nail beds, and palms, soles, and general skin surfaces. These are the sites you look for pallor. Then based on palmar crease, based on the palmar crease, if it is lighter in color than the surrounding skin, we can tell it is less than 7 or 8 grams per deciliter is the hemoglobin. Then if conjunctiva is papery white, or if retinal vasculature is very pale, then we can tell that it is less than 4 grams per deciliter. Then next is icterus. Icterus. How is icterus important? If icterus is present, we can think of hemolytic jaundice and other things, other hepatobiliary disorders like cirrhosis, all those things. That hepatobiliary disorders itself can cause anemia. So Wilson's disease, B12 deficiency, all these things. B12 deficiency also causes icterus. Then comes lymph adenopathy, very important. TB, mainly we'll think of TB, if not that, due to secondary to meds, lymphoma or leukemia. Then comes edema, again congestive cardiac failure or chronic renal failure. Hypothyroidism, very important. Then comes face. What do we look for face? Characteristic faces. What is the characteristic faces found in thalassemia? Sorry, Naveen, I could not get your doubt. Thalassemia, what is? Yeah, chickmunk faces, very good. Fanconi, what do you see in Fanconi? In Fanconi's anemia, what is the hypoplastic thumb? Yes, Sharanya, very good. Then you will see triangular face, microcephaly, all these things. That is very evident from this thing. Hair will be brittle in case of anemia. Eyes, again, pallor you look for, icterus you look for, any conjunctival hemorrhage you can look for. If there are retinal hemorrhages are there, then we can think of thrombocytopenia. Thrombocytopenia can be one of the cause if there are retinal hemorrhages. Okay. Then comes mouth. What do you look for in mouth? Angular stomatitis or glossitis. All these things, these are all features of vitamin deficiencies. Angular stomatitis means you can think of iron deficiency anemia, riboflavin, nicotinic acid, pyridoxine deficiency, all those things. If it is glossitis, then again we can think of iron deficiency anemia, folic acid deficiency. Magenta colored tongue you see in riboflavin deficiency. These are all important for your viva. They might ask in your viva. Raw beefy tongue you can see nicotinic acid or B12 deficiency. Atrophy of the papillae, that is nothing but bald tongue. This is seen in severe iron deficiency anemia, pernicious anemia, B12 or B9 deficiency. Then comes hypertrophy of gums. Hypertrophy of gums. This can be seen in acute leukemia. Which type of acute leukemia you see hypertrophy of gums? Anyone? Yes, specific. Aditya, very good. Then comes any acute inflammatory changes and ulceration. This can be seen in infective mononucleosis or hematological neoplasia. Mucous membrane is again pale. Unless we can make out if there is petechiae, then you can think of any bleeding disorders. So disorders. This was to do with the mouth. Then we'll come to skin. If it is pernicious anemia, this is important, very important. You will find lemon yellow tint. Again, an important MCQ question. You will see lemon yellow tint. Mixed edema, coarse and dry skin, and hypothyroidism. Petechiae and ecchymosis, again important, suggestive of thrombocytopenia. Then nails, very important is nail, examination of nail. Because in iron deficiency anemia, you will have brittle nails or flattening of nails, longitudinal ridging, or you can find spooning, koilonychia can be found. In case of chronic renal failure or liver disease leading to anemia, we can see white nails. Bony tenderness in the sternum, again suggestive of bony infiltration. Then coming to CVS, what all you can find, it is mainly the examination of findings of CVS are mainly due to anemia itself, like tachycardia, increased JVP, hemic murmur over the pulmonary area, cardiomegaly can be there because of hyperdynamic circulation, or any defective valve and prosthetic valves. Then comes abdomen examination. What do you look for? Splenomegaly. You look for, very important. If it is splenomegaly is there, then you can consider hemolytic anemia as one of the cause. Hemolytic anemia as one of the cause. Or else we can think of any hematological malignancy, myeloproliferative disorders, myelodysplasia, all these things. It will replace the RBCs because of increased proliferation. This will go replace the RBCs, so that will lead to less RBC production. Or hypersplenism. What is hypersplenism? Anyone? Hypersplenism. What is it? Then if splenomegaly is associated with fever, then you can think of infective endocarditis, malaria, hematological malignancy, etc. Hepatomegaly, why is it important? Because of anemia itself, you can have congestive hepatomegaly, tender congestive hepatomegaly, or in case of cirrhosis, wherein you will find shrunken liver. So then comes abdominal tenderness. Why is it important? We saw this before. Any abdominal mass for carcinoma or bleeding hemorrhoids. So these are the things. Then comes CNS. Again, because of megaloblastic anemia, usually you can have SSCD or peripheral neuritis. All these findings you can have. In SSCD, you will have UMN plus LMND findings both. Then peripheral neuritis, LMN findings will be there. Then comes RS, basal clefts we saw. So this was to do with the examination. By the end of examination, we can broadly categorize anemia into anything due to systemic disorder or due to blood loss, acute or chronic blood loss, hemolytic anemia, or hypoproliferative anemia. So hope the examination, you guys are fine with the examination. Why examination plays a very important role? Because we can directly categorize anemia into one of this. So history and clinical examination plays a very important role. Next, we look into how we classify anemia. Again, as we've seen before, we've already classified it. What are the causes for this? We'll just see in 2 minutes. One is due to blood loss. Okay, done. Second is due to decrease in RBC production. That can be due to impaired red cell production itself. That will be because erythropoiesis is not taking place properly. Why? We saw it in our initial chart that iron, vitamin B12, or erythropoietin, or folic acid, all these things, they act as factors that drive the erythropoiesis. So all these things, deficiency causes impaired red cell production, or depression of erythropoietic activity because of other secondary disorders like any inflammatory disorders, malignancy, connective tissue disorders, or infection. Then renal failure, there is decreased erythropoietin, so there is no drive. Then it can be due to replacement of normal bone marrow. Replacement of normal bone marrow in case of leukemia, lymphoma, the myeloproliferative disorders, myeloma, all these things. Or it can be due to certain inherited disorders like thalassemia. Then in the periphery, it is due to excessive red cell destruction. It can be because of the RBC structural defect, or it can be due to other causes. So that is what we call it as intracorpuscular. If it is a structural defect like hemoglobinopathies, enzymopathies, membrane cytoskeletal disorders, nothing but hereditary spherocytosis, erythrocytosis, all those things. Then comes, if it is acquired intracorpuscular, again, this is a very important MCQ. Which of the following is an acquired intracorpuscular defect? causing hemolytic anemia. PNH is the answer. Then comes extracorpuscular cause this is thrombotic microangiopathy, HHS or TUS, which you guys already saw. Then comes mechanical destruction by the valves or any toxic agents or drugs causing it, any infections causing it, and autoimmune conditions. So this we've already seen. So it was just to summarize all the causes along with classification. Next is the most important thing being investigations. What all we'll see in investigations? First, we should confirm anemia. Confirm anemia using, okay, we'll go a bit slow. I'm just going a bit fast because we have one more session. Your doubts, you can still keep asking. If I'm not able to clear it now because of lack of time, whenever you get doubts, please do ask. We'll reply it later. I'll just download this charts and reply to all your doubts, okay? So investigations. First one is complete blood count. In complete blood count, these are the usual laboratory tests that is done in anemia. CBC will have RBC, red blood cell count, along with HB, hematocrit, and reticulocyte count. Then comes red blood cell indices, which we saw, MCV, MCH, MCHC, and red cell distribution width. Then comes WBC along with TLC and DLC. This will have total leukocyte count and differential. So you guys are suggesting to have one more session for the investigation itself. Actually, I don't think so. This will take much longer. I'll finish it in 30 minutes. I will go slow, okay? We'll go slow and finish it within 35 minutes, okay? Next one is platelets. CBC, what all use? These are the usual laboratory tests in anemia. What all the laboratory tests? CBC, you will have RBC, platelet count, RBC indices, which you can derive from the RBC itself. Then comes the peripheral smear. Peripheral smear, what all you look at in a peripheral smear? These are the findings which you can look for in a peripheral smear. One is size, variation in the size. What is it called? Variation in shape. What is it called? Anyone? Answer is actually seen already. Variation in size, what is it? Variation in shape, what is it? Yes, that is what you look for variation in size and shape. Then through size, we can make out whether it is microcytic, macrocytic, or normocytic. And you can have variation in the shape of the cells. Pencil-shaped cells, tear-shaped cells, sickled cells, fragmented cells, all these things, various shapes. Acanthocytes, where is it seen? Anyone? We'll anyways deal with each individual aspect. Acanthocytes, where is it seen? Then comes, we look for pattern of staining. Then comes inclusions. What do you use to stain? Yes, very good. What do we use to stain reticulocytes? Reticulocytes are stained using what? Reticulocytes are stained using what? Yeah, any name? New methylene blue. Yes, very good. Okay. So these are the things which you look for in a peripheral smear. These are usually done by pathologists, so not dealing in as such in detail, but size, shape, pattern of staining, inclusion, any inclusion bodies if it's there, and if there are any aggregates or Rolex formation, and you look for other cells like white cells and platelets as well. This is what you see in a peripheral blood smear. Then you can do iron studies, which will again deal in detail now, and we'll look for B12 and folate deficiency. And finally, if we still cannot come to diagnosis, we'll do bone marrow examination. So first is CBC. In that, we look for hemoglobin, HP levels. So when do we tell anemia? When do we tell anemia in a non-pregnant female greater than 15 years? Non-pregnant female greater than 15 years. When can we call it as anemia? Yes, less than 12. Very good. In case of pregnant, when is it? In case of pregnant, less than 11. Yes. And men aged above 15 years, it is 13. Then we can classify anemia as mild, moderate, and severe. This is how we classify anemia. based on the hemoglobin levels as mild, moderate, and severe. For the values, you can just refer the table. Next, what do we do? Once we confirm that there is anemia, next we are going to rule out hemorrhage. First, we'll rule out hemorrhage as the cause of anemia through our investigation. So if there are clinical clues given, if clinically it is obvious, it can be either acute. Acute means it becomes very obvious. If it is chronic, again, through history, it is suggestive of it. And someone told, if there is chronic blood loss, it will lead to iron deficiency anemia. Yes, through history, and there will be features of iron deficiency anemia, which we'll study later. If it is not very evident, that is when it becomes clinically challenging. That time, what do? We can use ultrasound or CT abdomen or pelvis to look out for any retroperitoneal hemorrhage. Like retroperitoneal hemorrhage, it can be common if the patient is taking blood thinners like warfarin and all. If they present with anemia and we cannot look for the source of bleeding, we can just perform USG abdomen or CT abdomen and pelvis. Then if it is elderly, we should always do stool for occult blood. We should always keep in mind this has to be done. Then we can look for endoscopy and colonoscopy for occult GI bleeding. This is how we rule out hemorrhage. So first step was to confirm anemia. Second step, we ruled out hemorrhage. Third, we calculate something called as reticulocyte reticulocyte production index, RPI. Okay, so this is important. How is this different from the normal reticulocyte count? What we get in our lab is reticulocyte count. This is what we get, reticulocyte count. From this, we need to calculate RPI. Why do we do this? Anyone? Yes, you adjust according to good Avantika. What we get is reticulocyte count. Then we need to calculate something called as reticulocyte production index. Why do we do it? We'll see. By doing this, we do two corrections. We correct for two things. One is we correct for anemia. What is correction for anemia means? See, what happens is in anemia, RBC count decreases, but the reticulocyte count may remain the RBC count. It seems as though that the reticulocytes have increased. So to correct for that, we use the first correction. We use this using the formula. What is the formula? 9. So whatever the reticulocyte count, lab measured reticulocyte count. Okay. Lab measured reticulocyte count, retic count into the measured hemoglobin divided by 15, or hematocrit divided by 45. Okay. So this is the formula. If the lab values are given in absolute, if the lab says it is absolute retic count, then we don't have to do this correction because this correction will be done by the lab itself. But if the lab says only retic count, if this absolute word is not mentioned, then we'll have to correct for the anemia. That was the first correction. Second correction, why do we do is these reticulocytes that are increased in the peripheral smear, it can be because the premature reticulocytes have been just put off by the bone marrow. It may not be due to increased reticulocyte proliferation. Because of certain bone marrow disorders, these prematurely released reticulocytes are put out into the marrow. In that case, what happens is the survival of reticulocytes in the peripheral blood increases. When this happens, the reticulocytes values we tend to increase, but it will not be actually increased. It will be increased because of the longer duration. So to correct for this, what do? We use this formula. Whatever the retic count, lab measured retic count into hemoglobin correction divided by the maturation time correction. So what is it? So this is nothing but the first correction. First, whatever correction you've done over here, first correction divided by the maturation time correction. This is nothing but the maturation factor. What is maturation factor? It depends on what the hematocrit is. Depending on what the hematocrit is, if it is 45, we take it as 1. If it is 35, we take it as 1.5. See, the total duration of reticulocyte is same, 4. But if it is released early from the bone marrow, it will tend to survive longer. That is why we need to correct. So if hematocrit is 25, then it is 2. If it is 15, it is 2.5. So by doing this, we can calculate reticulocyte production index. What is the significance of reticulocyte production index? Using this is nothing but kinetic approach or physiological approach. We can classify it into hypoproliferative or hemolysis. So if it is less than 2.5, again, this value, various textbooks give various things. I've taken from Harrison. Harrison says 2.5, so I've taken 2.5. If it is less than 2.5 or greater than 2.5, if it is greater than 2.5, then it is hemolysis. If it is less than 2.5, it is due to decreased red cell production. So we look at this now. We look at decreased red cell production. Once we do RPI, next we'll go for something called as mean cell volume. This is one of the RBC indices, as we saw. How we calculate mean cell volume? Hematocrit divided by RBC in millions into 10. Normal value is 82 to 98 femtoliters. Using MCV, we'll interpret what is the size of the cell. Using MCV, we interpret the size of the cell. So it can be microcytic, normocytic, or macrocytic. Again, we will tell it is microcytic when it is less than 80. If it is less than 80, we can call it as microcytic. If it is greater than 100, we call it as macrocytic. That is how we decide. Once we do MCV, next we will do MC. If it comes out as microcytic, if MCV is less than 80, then we will think of microcytic anemia to be the cause. Most of the microcytic anemia will have hypochromic picture as well. To find out whether it is hypochromic or not, we use this MCH. MCH is, this is the formula. Hemoglobin divided by RBC in millions into 10. So the normal values are 27 to 33 picograms. If it is in this value, it is normochromic. If it is less, it is hypochromic. So we saw that RPI was less, so hypoproliferative. MCV we did. MCV also turned out to be less. That is why it became microcytic. Then we did MCH. MCH also turned out to be less. So it was microcytic hypochromic anemia. Next, if it is microcytic hypochromic anemias, we will do these tests. If this we find, we will do these tests: iron studies, red cell distribution width, and peripheral smear. These are the tests we do. Why? To differentiate 4 diagnoses. 4 basic differential diagnosis we get at this point of time: iron deficiency, chronic inflammation, thalassemia, and sideroblastic anemia. Through the iron studies, we will get to know serum iron, TIBC, transferrin saturation, and serum ferritin. So in iron deficiency anemia, what happens? Serum iron is low. Serum iron will be invariably low in iron deficiency anemia. But the saturation will be increased. Transferrin saturation will be increased because it has to supply more. So transferrin binds to more and more amount of iron to go and supply it to the stores. So transferrin saturation will be increased. Since transferrin saturation is increased, percent saturation will be decreased. Transferrin saturation, this saturation is nothing but iron divided by TIBC. Iron divided by TIBC is percent saturation. So since TIBC is increased, percent saturation decreases. Serum ferritin levels, storage form of iron, will also be low in iron deficiency anemia. With this, how we differentiate chronic inflammation is, in case of chronic inflammation, again, serum iron will be low. Serum iron will be low in case of chronic inflammation. But the TIBC will also be low in this. Serum iron as well as TIBC will be low. But the characteristic feature in chronic inflammation is, since serum ferritin is an acute phase reactant, that will also be more. So serum ferritin levels are high. This is how we diagnose chronic inflammation. Next differential diagnosis is thalassemia. Thalassemia, it can be variable as these values, but these values mainly you differentiate these 2 types of anemia. Okay, this will be variable. You can see in the tables, and sideroblastic anemia. These are the values. Main differentiate is to differentiate iron deficiency from chronic inflammation. How we differentiate iron deficiency from thalassemia is the next importance. For that, we do red cell distribution width and Menzer Index. Red cell distribution width and Menzer Index. Red cell distribution width, it measures the variation in size. In case of others, mostly in case of iron deficiency anemia, red cell distribution width will be more because there will be variation in the size. Because since there is deficiency of iron, few erythrocytes get enough iron and they mature properly. Few erythrocytes don't mature. So there will be, along with microcytes, there will be some amount of normocytes as well. So the variation will be will be more in case of iron deficiency anemia. But that is not the case in thalassemia. Thalassemia, it will be uniformly microcytic hypochromic picture. So red cell distribution width is normal. Next, we do something called as Menzer Index. This is nothing but MCV divided by RBC in millions. This also tells about variation in size itself. That's why it will be raised, but it will be decreased in case of thalassemia. So this is how we differentiate the four things. After that, we do peripheral smear. Peripheral smear findings, we all know, we have read very well in theory. If it is iron deficiency anemia, there will be anisocytosis, microcytic hypochromic anemia will be there because the cells are small in size and the central parallel will be increased. Only the 1/3 of the cell will have the hemoglobin distribution as we see in this cell. As we see in this cell, the central parallel is increased. Then comes pencil-shaped cells, again, pencil-shaped cells, teardrop cells, all these things. Variation in shape is there because of pencil-shaped cells. So it is poikilocytosis. Then we can do marrow iron studies. If we do Pearl's Prussian blue stain, marrow iron won't be there. Disappearance of stainable iron from the marrow will be there in case of iron deficiency anemia. If iron deficiency, look into the causes of iron deficiency anemia, it can be either due to increased demand of iron, increased iron loss, or decreased in iron absorption. This further we have to look at the causes of iron deficiency anemia. Next is anemia of chronic disease. If anemia of chronic disease is there, it will become evident from the history itself. So evaluate for those diseases. ESR and CRP will be raised because of chronic inflammation. Peripheral smear, microcytic hypochromic picture will be there. If it is thalassemia, peripheral smear, what does it show? Target cells, microcytic and hypochromic picture, anisocytosis and poikilocytosis will be there. HB electrophoresis becomes the confirmatory diagnosis in case of thalassemia. If it is beta thalassemia major, there will be increase in HbF. If it is beta thalassemia intermediate, there will be increase in HbF again. The amount of HbF increase is much more in beta thalassemia major as compared to beta thalassemia intermediate. If it is beta thalassemia minor, increase in HbA2 will be there by 4 to 9%. And at times, some amount of HbF as well might be raised. So this is how we confirm thalassemia. So what we did was we came to iron studies, we narrowed down the diagnosis, and we are doing confirmation now. Confirmation using peripheral smear and other tests. We've confirmed iron deficiency, we have confirmed thalassemia. Next, it is sideroblastic anemia. Sideroblastic anemia was one of our case. So what we saw in peripheral smear, there was dimorphic picture in peripheral smear. And depending on the etiology, if it is congenital, we'll find siderocytes in peripheral smear. And on doing Remnowski stain, we will find something called as Pappenheimer bodies. These are iron granules which are found in the peripheral smear or Pearl's Prussian blue. Then fine basophilic stippling as well is found. If there is coarse basophilic stippling, what do you think of? Anyone? If there is coarse basophilic stippling in the peripheral smear, what is the diagnosis you will think of? If it is, yes, very good, lead poisoning. If it is acquired, then look for all these etiologies, all these hematological disorders will be there. So it will become very much evident in the peripheral smear. If it is due to folate deficient or in case of alcoholics, there will be macrocytes as well, as we saw in our case, because it was alcohol induced, there were certain amount of macrocytes as well. Lead poisoning, coarse basophilic stiffening. Bone marrow, if you stain with Prussian blue, you'll find ringed sideroblast will be seen. If sideroblastic anemia is there, again, further evaluate for the causes. So next coming to, so microcytic is over. So if MCV is normal, then we'll think of normocytic anemia. Correct. So what are the causes of normocytic anemia? It can be due to chronic kidney disease. If it is due to chronic kidney disease, it will become very evident from the history, and on doing RFT as well, it will become evident. Peripheral smear, you will get echinocytes, wherein there will be regular blunts. How do you differentiate it from acanthocytes? How do you differentiate in a peripheral smear acanthocytes and echinocytes? Anyone? How do you differentiate echinocytes and acanthocytes? Yes, there will be regular. This, see, in echinocytes, the blunts will be regular. In case of acanthocytes, it will be irregular. That is how we differentiate. Irregular spikes will be there. Then, if we see pancytopenia, or if we see blasts in the peripheral smear, or it will be CBC is deranged, then we will think of any bone marrow disorder and hematopoietic neoplasms to be the cause. So these can be the cause. It will become very much evident in the peripheral smear, and if CBC is deranged, TLC, DLC, if you look at it, it will become evident. So diagnosis is easy. Then it can be due to pure red cell aplasia. That time you can think of parvovirus, B19 infection, drug exposure, thymoma, autoimmune disorders, all these things. If all these things are normal, or we cannot make out any of these things, then we can think of endocrine cause. So that time you will have to measure TSH hypothyroidism or testosterone hypoandrogenism. That itself can cause anemia. So look for these things. Next is MCV is high. So microcytic is over, normocytic is over. We'll look at macrocytic. We look at macrocytic. If it is macrocytic, most common cause is nutritional deficiency. So you look for B12 and folate levels. What will become evident? Megaloblastic anemia. One is B12 deficiency. So cobalamin levels will be low. If cobalamin levels are subnormal, then we'll think of methylmalonate or homocysteine, because these can diagnose megaloblastic anemia much earlier. In its subnormal stage itself, it can diagnose. So this will be raised. Methylmalonate and homocysteine will be raised. Okay, that is the importance of methylmalonate and homocysteine. And then we'll assess for cause again. After diagnosis, we'll always assess for cause. Megaloblastic anemia, again, if in case of strict vegetarianism, or it's due to malabsorption, alcohol, any resection surgery and all can be the thing. And we'll do Skilling's test to rule out perinaceous anemia. If perinaceous anemia is found, there will be parietal cell antibody will be there, which will measure for, that will turn out to be positive. And if we do endoscopy and take gastric biopsy, there will be gastric mucosa will be flattened. Flattening of gastric mucosa will be there due to antibodies. Flattening of gastric mucosa will be there. Then comes folate deficiency. Serum folate will be reduced. Again, assess for cause. Causes are almost similar. Megaloblastic and folate causes are almost similar. Assess for the cause. In peripheral smear, what do we see? Most specific is hypersegmented neutrophils. It is hypersegmented neutrophils. When do you call it as hypersegmented neutrophils? When can we tell it is hypersegmented neutrophils? Greater than 5. Greater than 5. Okay, it is greater than 5 or greater than 6. Greater than 6 in one peripheral smear. If it is multiple peripheral smear, then it is greater than 5. Then you can Cabot rings. You can look for Cabot rings, anisocytosis, poikilocytosis, and macrocytes. All these are peripheral smear findings. If we do bone marrow, is not done. If we do bone marrow, we can find asynchrony because there will be nucleus DNA defect. So there will be asynchrony. Giant metamyelocytes, band forms because other precursors, other granulocytic precursors as well get affected because of the nutritional deficiency. All these things, and hypercellular marrow. So if we can rule out that also, if that is not the cause of macrocytes, then we can think of aplastic anemia and hepatobiliary disease to be the cause of macrocytic anemia. Hepatobiliary diseases and aplastic anemia cause macrocytic picture. Okay, again, aplastic anemia itself is very huge. Approach to aplastic anemia will be again dealt later in some other class. Okay, then comes, so we are done with hypoproliferative anemias. We are done. Next is hemolytic anemias. Next is hemolytic anemia. Hemolytic anemia, one, you do history. Next, we'll measure serum LDH and serum haptoglobulins. If they are raised, LDH is raised and haptoglobulin is decreased. Why haptoglobulin is decreased? Answer through the charts. If LDH is raised and haptoglobin levels are low, then we'll think of intravascular hemolysis. Then we'll think of, yes, very good. It binds to hemoglobin. Okay. Intravascular hemolysis. So if there is intravascular hemolysis, first test we do is always direct Coombs test. We should always do direct Coombs test. If direct Coombs test is positive, it will become autoimmune hemolytic anemia. If it is negative, again we'll further proceed. If it is positive, then it is AIHA. If it is AIHA, then you will measure serum IgG levels. Serum IgG levels. If serum IgG levels are elevated, then it is warm antibody type. If it is not elevated, then it will become cold agglutinin type. It is because of IgM. Complements will be elevated in both. Then again, you look for causes. These are the, again, there are wide range of causes for both. These are the causes, okay? These are the causes you look for. Peripheral smear will again show spherocytes. Which is the most common cause of spherocytes in the peripheral smear? Most common cause of spherocytosis in the peripheral smear. Anyone? Yes, it is not hereditary spherocytosis, it is autoimmune hemolytic anemia. This is the most common cause of spherocytes in the peripheral smear. And you can, in cold agglutinin type, you can find clumps of RBCs as well. If direct Coombs test is negative, then we'll do peripheral smear and confirm the diagnosis. Like G6 peri deficiency, you'll have Haynes bodies, usually on supravital staining, and bite cells. You will find a bite cell over here because the spleen has bitten onto it. That is causing this picture, bite cells, but it is not being destroyed properly, which has led to bite cells. Then if it's malaria, you will find certain RBC parasites and inclusion bodies. If it is babesia, crossotic appearance will be there. If it is secondary to mechanical trauma, then you will find schistocytes, helmet cells, triangular cells, all those things. Then coming to, these were the causes of intravascular hemolysis. Then is the extravascular hemolysis. Extravascular hemolysis. One is hereditary. These are mainly the structural defect. So hereditary spherocytosis means you will find spherocytes, Howell-Joel bodies, and increased MCHC. This was also there. This was also there in the first case, which you guys did not catch up. MCHC was raised. MCV and MCH was normal, but MCHC was raised in our first case. So that is also there. Then what are the screening tests? One is osmotic fragility test, because it is a spherocyte. It is more fragile, so the curve shifts to the right. And there can be confirmatory test, that is EMA binding test. This is the gold standard for hereditary spherocytosis. If it is sickle cell anemia, there will be sickled RBCs, target cells, Howell-Jolly bodies, all those things. To this screening test is sodium metabisulfate. This is sickling test. It causes sickling of RBCs. Confirmation is HPLC is always better than HB electrophoresis. So this was the whole class on our approach to anemia. The whole purpose of the class was that we are all of us are good at theory. We have learned theory well and we are good at it, but what we lack is clinical skills. So it was to stress upon history, clinical examination, and investigation, and how we approach to anemia. In simple, this is what we have learned today. What we have learned today is, for anemia, you should always have a good clinical history and examination. That is the key. After that, we'll generate differential diagnosis. On doing differential diagnosis, after that, you confirm anemia with CBC. Then we do reticulocyte proliferation index, less than 2.5, greater than 2.5. If it is less than 2.5, you'll go measure MCV. MCV is decreased, it is microcytic hypochronic anemia, and its 4 causes. After doing iron studies, all these 4 causes you can think of. If it is MCV is normal, then it is normocytic normochronic anemia with its cause. If it is increased, macrocytic anemia along with its cause, and specific tests for each are there. If it is greater than 2.5, rule out blood loss. Rule out blood loss by doing occult blood, stool for occult blood, endoscopy, colonoscopy, all those things. Or if the blood loss is not there, think of hemolytic anemia. Hemolytic anemia, measure LDH, haptoglobin. If it is raised and haptoglobin decreased, then always do Coombs test. If Coombs test is positive, it is AIHA. If it is negative, then these have their specific tests. If it is normal, then think of structural disorders with its specific test and peripheral smear. So hope you guys understood. Your doubts, whichever has not been cleared, it will be answered. Your chats are recorded, so it will be answered and sent, okay?